officially 10:25, so we'll go ahead and get started. I'm Taylor. I'm the host of Solution Group 3, and I'm so happy that you could be here today for this S4CC conference and this portion of it. So Solution Group 3's topic for today is integrating psychosocial care across Cleft specialties. And just as a kind reminder that if you would like the interpretation, that if you go to the bottom here and select this, and there's real-time translation into Spanish and French. Also a reminder that please use the chat feature throughout this if you have comments or questions, and then also during the Q&A section to use the reaction feature to raise your hand as well. So for Solution Group 3, we have a variety of specialties. We have psychologists, dentists, speech therapists, surgeons, and a social worker represented in our group. First, I would like to begin by acknowledging the wonderful work of our co-chairs, Lola and Sunam, for all that they've done. They've really guided us through this process and been key to getting the findings and coordinating our group for what we're going to do today. And also Andrew, who's our scribe, who's also been really helpful and key to getting this information conveyed. It's also super important to acknowledge our SG members who helped create this PowerPoint you're going to see today and are going to be involved in the roundtable discussion. So these are all of our wonderful SG members who have been involved in this process and that you'll be seeing and hearing from today. So now that we've gone through the introductions, you'll be hearing from one of our SG members, Phantom Wine. So I'm going to pass the baton to her now.
Thank you, Taylor. So greeting for all. We started our topic by having common understanding about why is the psychosocial care important and what is psychosocial care and why and what do patients expect from us. As we all know that having Cleft children in the family could lead to the environmental impact and psychological stress, both on the parent, family members, and the child. Parents especially seek to know the causes, worry how to cope with the situation, on how to give the answer to the relatives and neighbor on why their child is different from others. Why also need to learn how to get the child repaired and rehabilitated. That the Cleft care must concern on social well-being and which need psychological care for support given to help meet the mental, emotional, social, and spiritual needs for patients and their family. While also refer to an individual's social, cognitive, and psychological development interaction with their environment. To cope with those parents, next slide, please. To cope with those parents expect to get the complete information from the medical providers for making decisions. That medical providers need to have effective communication free of complex medical terms, easy for the parents to understand. This is not only for the patients and their families to reach, all of those information, but also go beyond to wider community, including teachers and peers, by using different social media tools. I think I covered next slide already, Taylor. This is the information that go beyond the patients and family. Wider community and all other peers and teachers and the public also should know about the information related to the care. I would like to invite the Carolina to continue, please.
Thank you. Well, thank you all for being in our group. This group is specifically like a huge compound of all the things that we have been heard in SG1 and SG2. So in our group, we had a literature review, and we have shared many articles related to how psychosocial care has a huge impact in LMIC context, and how we can see in a different perspective with all the mental well-being that sometimes, or most of the times, in a lot of LMIC contexts have been stigmatized. Also, that we know that every member in our specific team deals with a lot of not only cleft abnormalities, but also different syndromic situations that may be complicated for their families and for all of the persons that are around these kids. Next slide, please. So one of the most rich things about this was that we work in a survey, and we had a lot of respondents. We have 110 respondents with a total of 36 countries that participate. And from these countries, we had 22 from LMICs and 14 from HICs. And well, there were very, very interesting how the LMICs responded, because, well, in my perspective, and I know that, you know, a lot of the participants of this group perspective, there are a lot of things that we had never thought before. So that's why we're gonna be talking about in this moment in our recommendations. Next slide, please. Okay, only for you to see, there was a lot of participation from different specialties, but most of them were speech. And this is very interesting because from many years ago, I listened always to Hugh saying that when you don't have a different professionals in your team, you have to absorb all the knowledge and start sharing with all of the professionals so you can support the family as you can. And that's what we can see in this respondent disciplines. Next slide, please. Okay, so we have seen that in the survey responses, 80% of them were part of the Cleft team. So this is very important. So as the other participants were saying in the other SG, we all are talking the same language, and this is a very important thing. And also, like in the last SG, one of them were saying that there's a lot of patience and a lot of love related to the cleft population. So this is very important. Also, that the 80% have received any training or some training in the psychosocial care area. But this is very important because we can receive the information and we can receive the training, but how much we apply this training to real life. Over half of the respondents have been involved in the cleft care of more than 10 years. So this is also very important because it's not only to meet a lot of families during these whole 10 years, but also that every year, all the families like questions or way of thinking or cultural situations were gonna be changing. So we have to be more like this open-minded to different situations that can be happening year through year. Well, then also 95% of the respondents believe that the care will be improved if psychosocial aspects were integrated from the beginning. And it's a huge deal. I have been listening to all the groups, and they're saying that we should be explaining or we should be telling the families. But one of the most important things here is that it doesn't matter if you explain the information before starting the all this process, not also clinical, but rehab too, because the parents have so many things in their head and their families too. And what happens here is that even during the whole process, they start forgetting the things. So one of the most important thing here is that psychosocial aspects should be reinforced in each step of these kids' process. Also, that we have major challenges in LMICs, including lack of information or inadequate trainings, also lack of support or lack of assessment. And this part, it's very controversial, because when you talk to families, they will say, oh yeah, we can accept this situation, or we feel very comfortable feeling with this diagnosis. But you can see through the years that's why it's so important to be working in the psychosocial aspects during all this process of the treatment, because you can accept it in one step, but suddenly you pass through another step or to another chirurgical process, and this acceptance will be again in this process, like starting again. So also we have a lack of skills or experience, and a very important aspect here is the lack of time. Sometimes we focus in our work in the specific areas that we should be working, and we leave aside the part of the psychosocial aspects. So this is something that we should be continue working as, not also as a team, but as a professional itself, that time, we have to work on time to explain the families and the patients to the importance of the psychosocial aspects during all this process until the kid is out. Also, we have a lot of major barriers in the LMICs. There's like the scarcity of locally support, the lack of foundations, the lack of Cleft special professionals, and the psychosocial care is not a family priority. And this is very important too, because sometimes we focus on that you only need psychosocial care if you feel bad, but it's not that. You can start thinking that if you have the basis of a great psychosocial care, you can be able to make support to these families or to the kids that are receiving all the treatment and not feel bad about it. Next slide, please. Okay, I'm gonna be talking about the survey themes. So one of the, for me personally, one of the most impact topics was the cultural and religion barriers in the LMICs. And this is because some of the comments were that the cleft was caused by evil forces or spirits or karma or curses. And you might think that in 2023, people continue thinking about it, but yes, there is that kind of way of thinking, and it's something that we should start working about it. I always tell in my sessions that there are not dumb questions, only dumb people who doesn't make questions. And this is a very important thing, because sometimes the families go to their homes and think that this is because I did something wrong, or this is because I didn't want this baby, and suddenly the baby was born with a malformation. So, or even though the mother is blaming herself because of this cleft. So families who have support, like we listened in the last group, and have the correct information and psychosocial care support, they will be more relieved that they know that there is not their fault, or that there is not anything wrong with their kid. And that also, if we give the correct information at the first time or at the beginning, it doesn't matter if you give the information at the beginning and repeat it in the middle and then continue in the end. It's always important to make this clear to their families and understand, because at the end of the day, the kid will start growing and he or her will start thinking that probably it's true about the things that they're listening in their social circle. Also, that the treatment should be not challenged by God's will. It's very interesting that probably sometimes we think that if God sent us this baby this way, we should not be making any surgery or any rehab, because this is the process that God wants me to do. And this is a very important thing to let some of the LMIC's countries very clear, that all of the kids and their families have these situations or the accessibility to receive all these treatments. Also, that we have a lot of variety of languages that is being spoken in different countries, and that cleft is not widely known as a condition. This is very, very important. In summary, the survey revealed that there are not standardized psychosocial screening tools for LMICs, and that there's not available or sufficient available psychosocial care. Next slide, please. Okay, so we're starting in our favorite part of this group. This is the recommendations. Next slide, please. First recommendation, it's to improve awareness and increase advocacy. And one of the things that I was telling to my group partners is that we are providing you the recommendations, but for me, this is like 1 + 1 + 1 + 1 equals the 4 recommendations. Like, you cannot think, okay, I'm gonna be using the first one, but probably I'm not gonna be using the second one. And it's not about it. It doesn't read about it. The thing is that we need all of them to make a huge difference in our patients and community and families process. So in this first recommendation, we have the raise awareness of the cleft in all the range of levels: family, communities, regions, government, even schools, because schools and teachers are a great area that we can support for making this awareness, not only for the kids and their families who had cleft, but for all the kids that are around it. Also, we address the following concerns: acceptably, but the couples, family, and community, the social stigmas, the caregiver relationships, participant self-esteem, and participants' self-pity. And this is a very important thing. Like I was telling you, that we should be working since the beginning. If we work from this, probably all of these concerns that we are thinking that they're very important would probably disappear or minimize. And we can work in a lighter situation than if someone doesn't think that this is very important to be in work, and suddenly it's a teenager that has to work a lot of his or her self-esteem. So we should be working a lot of this. Like, we have to take time, even we have explained the process or the chirurgical procedures or the rehabilitation process, that this should be work since the zero moment, and not only with the families when they have a baby. That's why we should be working in a lot of information, providing information to everyone, even though if they don't have cleft kids or with another situations, they should be known that there is information that they can access, and they can understand that even they have a baby, they can look for support. Next slide, please. So we have the recommendation number 2, that it's offering training. Probably you're gonna be thinking that, well, I have been received 1 session training, or, oh, this is so boring. Well, it isn't at all. Sometimes we need to get training, not only for our patients and their families, but also for ourselves. like I was paying attention in the SG2, we all not only working for the families, we're working for ourselves too. So this training, it's gonna be standardized for the entire team and to provide the psychosocial professional using the evidence and informance approach. So it's like having all these tools that we can use and apply to not only their families and their patients, but also to another of our Cleft member teams, that some of them will probably need this support, or probably me as a speech, I will not get all the knowledge about how to manage a situation, so I can go and look for help to another Cleft partner. This training should be incorporated in a specific roles, and it's a lot of importance in responsibilities and lines of communication. We should be having all these channels open. Sometimes we tend to think that communication is so easy, talking it's so easy, but suddenly we close all the doors and it isn't easy as we thought. So we should be having active communication lines to make this training more open. And we have lack of training was identified as a key challenge in this survey. So even we don't have any psychosocial specialists in our teams, it's very important or crucial to have this training, and that everyone can, in different languages, obviously, can understand all this process and support these families. Next slide, please. Well, recommendation number 3. So increasing support. So we have now that we can receive all this knowledge and we can look for different groups of support, and then we have the training, but now we have to increase this support. So how are we gonna be doing this? Well, secure by in front of the hospital management or community leaders or founders that can provide to start sharing all this psychosocial support. We can make a lot of this huge network of information, and we could start sharing. Probably if, I don't know, dentists will not be in specific like feel secure of talking about psychosocial support, it can be the key to start doing the networking with the different Cleft members and giving the correct support or more support that the families need. Because we have to understand one of the things, that the families, they're not only concerned about the Cleft situation, they had a lot of situations in the emotional areas that could affect, at the end of the day, the Cleft process. And also we have to work on this trained utilization and funding of psychosocial services. So, well, at the end of the day, it resumes if you as a team don't have psychosocial care provider, you should be having one. Obviously, it will be a perfect world with it, but also have a good training in our team or in the team that you're working for. Next slide, please. And then we have recommendation number 4, that it's research and development. And for me, and I know that for our team too, it is very important, because you cannot start doing research and having development if you have not been trained in psychosocial care, and if you have not been, well, having more networking with psychosocial specialists, or how are you going to be managed or talking about how to support families if you don't have the knowledge before it. So this is very, very important thing to evaluate an evidence-based information approach. Also, identify the gaps and deficiencies in the patient's care and supporting LMIC context. And here, well, we are thinking about the NGOs, how the NGOs can support us in all of this research or development investigations, or even publishing articles related to very specific information. Because at the end of the day, we're not dealing with a number, we're dealing with people, and they have feelings and emotionals and a lot of situational personal issues that can be reflected in all of this process, and that can make the process of the surgeries and the rehabilitation less functional. Sometimes family thinks, oh, it got the lip repair, so it's perfect. Like, we can't make a side and the people will not care about how it's gonna be speaking, because my concern was only the aesthetic. And it's not true. It isn't at all. If we place a balance and we have in a side the rehabilitation area and the clinical area, the chirurgical area, we cannot make a balance if we don't have the psychosocial here in the middle. And this is actually our glue. So if we have a lot of information and we have this support to the families, probably they will understand that looking good is not the things that we're expecting to. Yeah, if you're looking good, that's great, but it's also looking good, talking good, and feeling good. And we have to be thinking about this way. Clear research enable greater support for management things, increasing the expansion of psychosocial care. And probably you will be thinking, oh, she works at psychosocial care, but I'm not. I'm a speech, and I do think that we should be learning in any aspect and from a lot of persons different things, and we can apply to our reality. So this is why I do think that NGOs as TIA with these projects are huge, important things for expanding the networking and making connections, not only with the people in our country, but in different countries and with a lot of experience too. Support the creation on translating and using standardized psychosocial screening tools. And this was very, very interesting, because in one of our articles, we were talking about different screening tools, and we were like, we don't have this in this language, or can I start changing some of the words to apply, or how can I measure or research if I don't have the screening tools in my language? So this is something that we should be thinking about it and promoting always in the Cleft team. Next slide, please. Okay, so I'm gonna be leaving you with Fanowan.
Thank you. We would like to call your attention to illustrate of what we heard in the survey, and our recommendations are grounded in reality. Most of the quotation confirm that there are barriers on cultural and religion, and the family seeking treatment late due to shame, being seen as mother fault, karma, as curse, or as a sin to change what God has given them, as you can see on those quotations, especially from the Malaysia. You can see that what happened. Can I continue? Hello.
Yes, continue.
Some parents believe the Cleft is God's way of punishing them for whatever they did, and then they're reluctant to seeking treatment due to that belief, and they are not support since they are not supposed to change what God has given them. So it's taboo. So they are away from society and keep their child at home and do not seek treatment. Next slide, please. Some barriers from difficulty in understanding information due to different languages in the country, like the quotation from Nigeria. And there are also some barriers from not widely screening tools using or no standardized tools using to make known of the psychosocial problem of the Cleft. As you can see on the quotation from Malawi said, I don't use any, not sure that the professional psychosocial providers do use. And in protocol, we don't use any. And I usually use in other health conditions, but non-specific for psychosocial needs for parents and family. And with the Cleft translated in Portuguese and with transcultural adaptation. So I think this is the big gap and big barrier on how we can improve the psychosocial care to our Cleft patients. Next, please.
So that concludes the presentation, I believe. So now we'll get started with the roundtable. And just as a kind reminder for this roundtable portion, please feel free to type in the chat. And also, if you'd like to speak, please use the reaction feature to raise your hand. And our co-chairs will be kind of facilitating this section, so they'll be able to answer and address some of the comments.
Any reactions, comments, feedback, anything that resonates with you?
Felicity's hand is up. And Dela Lusoya.
I only put it up because I didn't see anyone else's. Just to say again, what a superb session. Thank you. And so insightful, so much to think about. One thing that really struck me was your slide. I made a note, the major challenges to implement psychosocial care. To me, they fell into two groups. One was around resources, training, time, funding, all of which are problems we all face. But there was another one that maybe is a quicker, easier, cheaper thing to address, which was lack of family support and acceptance for the need for psychosocial care and the lack of psychosocial care not being a family priority. And I think maybe we could do something around messaging to make it be normal, just as you would expect to see a surgeon in a Cleft clinic, a dentist in a Cleft clinic. We should see a psychologist or a psychosocial worker in a Cleft clinic. And to me, that, you know, all the money and resources in the world may not change that. So it's almost like we need a double-pronged approach to address this. I wonder what the group think.
Well, I don't know if anyone wants to respond to what Felicity is saying.
I would like to add something to that. I believe sharing
Madam,
information. Can you hear me?
You take that.
Okay. I believe sharing information on the activities that are being carried out on the sessions, on psychosocial sessions to the families, it's very important to let them know that it's not something boring or just another responsibility or another treatment to the children. It's very, very important to let them know that it can be
Yes.
fun and helpful, and a safe space for them to share their experiences with another adult that will hear them out and they will counsel them, and an opportunity to grow. So it's not just like that. Imagine that picture that they have of just sitting and having a professional teaching them or saying stuff to them. Is just a safe space and a fun space where they can learn new things and speak about how they feel, but in different fun ways. So it's not always, it's trying to let them know, the families know, that the psychosocial sessions is not just a boring or another treatment, is a fun space and an opportunity for the children to grow.
Thank you so much, Angelica. Adiela?
Okay, thank you. A nice session. I was just wondering, when it comes to this psychosocial aspect of cleft care, one challenge that resonated quite loudly in my center and my environment is what kind of tool to use. I'm asking this because I'm just wondering if there's a popular tool, the way we have like the Cleft queue for assessments generally, but is there a popular tool for psychosocial well-being that one can suggest?
I can answer that question, but I would be also very happy if anyone is using any of the, scales or tools that they would like to share. What you're asking, Adela, is that are there any tools that we look at for psychosocial well-being?
Yes, that's what I'm asking, but they're commonly used, so to speak, not just to identify one in particular.
That's what she's asking.
Commonly used, yes.
Yeah, so I think based on research, based on what we have surveyed, CBCL, Child Behavior Checklist, and SDQ, Strengths and Difficulties questionnaires, are usually the tools that are used to assess the well-being, like psychological well-being of the patients. Is that what you're referring to? Does that answer your question?
Yes, it does. Thank you. It does, thank you.
You're welcome. Christina?
Hi, I'm from McMaster Children's Hospital in Hamilton, Ontario. This whole morning has been wonderful, and I feel like things kind of built up on each other and pulling things together. At our center, I think that all of our team members have different strengths and comfort level and abilities. When there's something that requires a little more psychosocial care. So I think training for all of our team members, including those extended team members like the dental group, would be helpful. Sadly, we had a social worker with our team, and she would sit in on all of the developmental pediatrician's appointments and all clinic visits. And part of the nice thing of that is our team developed a rapport with her. And even if families didn't express something in their visit, they have sort of a face. And if something comes up, down the road, they might think, oh, we met that nice social worker that one time, I'm going to reach out and see if I can chat with them, because, ideally, when you have somebody that has even more training, like a social worker or a psychologist, to really address, some more specific needs is wonderful. We all need to kind of help support that family. But it's quite unfortunate. I know from our end of things that's a resource that we've lost.
Thank you. I think like what you're saying is very important, because like the personal relationship is the crucial thing, right? Like once they feel that rapport, that's the thing that makes it actually makes a difference and makes it more valuable to pursue like psychosocial support.
Mhm.
Thank you.
Welcome.
George?
Thank you. I'm George from Uganda, a plastic surgeon. This was a very good session, and I wanted to highlight two things. One, that the need to have psychologists, clinical psychologists, and social workers on a Cleft team benefits the parents and the patients in a much more diverse way than just having one of them. And of course, if they're not both available, having training for the field that is missing is quite crucial. And that would be something that would be beneficial going forward from today, to let teams know that this is actually quite important. Then the second thing is, I think I heard that some parents think they're being punished by God and therefore wouldn't want their child or themselves, if they were the patient, to be repaired. That's actually a little bit different in Uganda, where in fact there are names for patients with disabilities, congenital anomalies, and there's a set of names. So these people feel like they were cast by God rather than punished. So they're quite keen on having the child or themselves seek surgical repair. So the missing link then might be where to access it, but they're quite keen on having this done. Unfortunately for some, they actually perform infanticide when they feel they're cast by the gods and therefore get rid of the curse. It's actually quite problematic in some parts of the country where we felt there were no clefts, and it just wouldn't explain that. Then we found out they were actually being killed off as infants. So this aspect of psychosocial integration into the Cleft team care and service is actually quite important.
And I'm also in line with what you're saying, George. I'm also following the discussion on chat, and what Yuri is saying about like the differentiating between having a psychologist on the team and psychosocial support, I think is very crucial. And the reason for that is, I think for psychosocial support to be in the forefront, we need all members of the team to be fluent in that kind of language and the way that they present information and they support their patients. So I think I think the first step, even if like having a psychosocial person is at this time too much to ask for, I think what we need to start with is that having that concept, that framework in every team member's mind so that they can support the patients.
Great. That's it.
Diana.
Hi, hello, everyone. Very interesting conferences, and echoing other colleagues' messages. I'm the Senior Program Director for Smelter South America, and I'm a psychologist myself and have worked with family for many, many years, although now I work under more of an administrative capacity. Nevertheless, psychosocial work should start with the beginning of the treatment, when the mother realizes that she's pregnant, because that will help the family understand what they're going to go through, understand that they're starting a journey, and will help the family also for the adherence of the treatment and how they're going to deal with their child. Psychosocial or psychologist support should not start when the child is 16 years old and has gone through a series of surgeries and cannot speak well. So now we have a teenager with a problem, But if we start since they're little and we start reinforcing them and working them and with the family, and can be done by psychologists, by a trained social worker. Like in the US, social workers are trained to do therapy, but cannot be done by a speech therapist, cannot be done by a doctor. I mean, nevertheless, I think that the whole team should be trained to understand and to learn or read some cues, because not everybody can receive maybe psychosocial services if there's especially a scarcity with professionals. But in this path, I guess we have learned to identify families that are going through more difficult times than others, and those are the ones that should be addressed and help, and also provide, for example, support groups for parents, for children, activities that will engage the family. Smartly, we develop a 9 Reasons for Smile booklet. So those are activities that engage the family, that engage the community. Having like our Cleft, we try to have activities not only the professionals, but the families as well. So, and also helping to develop capacities as organizations, as large as we are, we're working on developing capacities, having maybe strategic partnership with the universities where there's not too many professionals. So there's a lot of things that needs to be done. I guess we are starting to work on that. We have great success in the projects that we have. There's one that fills me with joy, which is Project of Life, that Clínica Noel, our partner in Medellin, does. Our partner also in Misión Caritas Felices in Peru, they've been providing psychosocial support, and basically kind of like all the patients go through a screening session of 1 or 2 sessions. So there's a lot that can be done. We just need to start little by little, focusing on the people that we have that can help us, and then growing from there. Thank you for inviting me here.
Thank you. Ximena.
Muchas gracias. Soy Jimena de Fundación GANS en Chile. Estoy totalmente de acuerdo con lo que acaba de exponer Diane. Pero yo tenía varios puntos que comentar. En nuestro centro, desde hace muchos años, sabemos que el apoyo psicosocial es fundamental. Sin embargo, obtener los recursos para poder implementarlo ha sido sumamente complejo porque pasa a ser una necesidad de segundo orden. Primero está la cirugía, segundo el tratamiento del habla, el tratamiento de ortodoncia, y finalmente, como último recurso, si queda algo de dinero, psicosocial. Gracias a un proyecto que realizamos en conjunto con Transforming Faces, un proyecto maravilloso que nosotros en Chile perseguimos varios años sin lograr apoyo, hemos podido implementar el equipo de manera completa, psicopedagogo, psicólogo y asistente social. Y hemos notado, primero, la dificultad para las familias de adherirse al programa. Como alguien comentó por ahí, es como para personas, la gente tiene la creencia que es para personas con dificultades mentales. Sin embargo, el apoyo comienza cuando la mamá está esperando su guaguita, su bebé, y sabe que tiene fisura. Viene la contención de los padres para poder iniciar un camino de desarrollo, como comentaba Diane. Poco a poco hemos ido aumentando la adherencia al tratamiento psicológico y el tratamiento de psicopedagoga. Psicopedagoga, no sé si existe en otros países con el mismo nombre, pero es un apoyo especializado en la educación. No hacer tareas, sino que aprender a aprender. Y mi tercera observación va por un punto bastante más general, que yo he notado que faltan herramientas comunes de evaluación que permitiera saber en qué escala está. O que permitiera evaluación familiar, evaluación personal, y la idea es que esto evolucione, pero estamos haciéndolo con con lo que creemos que es una buena herramienta. Sin embargo, creo que de manera global deberíamos tener estandarizadas herramientas los diferentes centros para poder compararnos unos países con otros y mejorar las prácticas. Finalmente puedo comentar que el trabajo del asistente social, en nuestro caso, es poder hacer justamente, como comentan aquí, un triage, o sea, poder clasificar a las familias según su necesidad y según su ingreso económico, no solo por ser parte de un grupo, sino para poder dirigir lo más enfocadamente los pocos recursos que se tienen a los más necesitados. Así que quiero cerrar dando las gracias nuevamente por el apoyo de Transforming en este proyecto que yo perseguí durante 4 años y finalmente lo pudimos implementar y estamos en la mitad del proyecto, que esperamos que sea un proyecto exitoso y que se pueda replicar en otros países con las mejoras que correspondan. Y muchas gracias por esta fantástica oportunidad de aprendizaje del día de hoy.
Thank you so much, Jimena. I was thinking about a couple of things when you were talking. I think like it's so valuable for people who have done projects integrating psychosocial to Cleft Care to share what they have done and what worked, so that we can maybe like use parts of it to implement it in our own respective contexts. And the other thing is, I think for me, what you're saying always goes back to advocacy and funding. So anyone here who has the power to make things happen on that level, please like be aware that we kind of need your support. Diana and then Felicity.
Bueno, muchas gracias, muchas gracias. Yo quería como comentar varias cosas, sobre todo me gustó mucho el comentario de Angélica en cuanto a que el soporte psicológico no debería ser una consulta más, ¿verdad? Esto debería ser algo que estimule a los niños y al resto de pacientes, ¿no? A estar adheridos a su tratamiento, a venir al hospital. En un contexto como el nuestro aquí en Oaxaca, y haciendo todo para poder ofrecer un tratamiento integral, el incluir un psicólogo en el equipo siempre es un reto, ¿verdad? Es algo que todavía está reconocido por todos los miembros del equipo que es necesario, pero es como aquel como lujo al que no podemos siempre acceder, ¿verdad? Entonces, una forma de paliar esto fue, apareció una persona que es técnico en juego. Él es una persona que es especialista en educar a través del juego. Entonces él se interesó en el proyecto y vino, estuvo con nosotros 6 meses y entonces ya la sala de espera se convirtió en un playground, ¿no? Era un parque para los niños. Y con una intervención de solo 6 meses por una persona que era especialista en juego, más no en psicología, pero que sí que tenía mucha mano izquierda, ¿no? Para manejar esto, los niños empezaron a decir que el día más feliz de su mes era el día que tenían que venir al hospital, ¿no? Entonces, sí que es importante que no todos estamos entrenados, sobre todo los cirujanas y cirujanos no estamos entrenadas para brindar apoyo psicológico, pero sí que es importante, sobre todo en un contexto como este, el estar abiertos y abiertas a la posibilidad de poder ofrecer ese soporte de otra forma, ¿no? Ahora estamos buscando la manera de poder integrar un proyecto para volver a traer esa persona, porque si bien no es una cosa o todavía no es reconocida como algo vital en la rueda de tratamiento, sí que marca una importancia, ¿no? Que cambia completamente la experiencia del paciente. Entonces esto era algo que quería contarles, esta experiencia que tuvimos, y apoyar y agradecer el comentario de Angélica, ¿verdad? Porque es como, claro que esto debe ser algo divertido, ¿no? Para los pacientes, algo que alivie, no otra visita más, ¿no? Muchas gracias.
Thank you. I think it makes total sense that, they're not just going through another evaluation, but they're doing something fun. And then what you were saying, I think, reminds me that it's basically comes down to human connection. So once you make that happen, I think it will be a different experience for every consult. Felicity.
I just wanted to say about the importance of the role of all Cleft team members to give that psychosocial support and to provide all Cleft team members with just the basic amount of training, a bit like we see it as our role, even as non-dentists, to promote good oral health. And that's a similar principle, but I think it goes even broader than that. A principle of clinical care is, above all, do no harm. And sometimes when surgeons say things like, I will make you look better, I will make you look normal, or we have caused harm. When mums say to us, I will never forget the look on the midwife's face when my baby was born. They took the baby away. I knew something was wrong, but no one talked to me. All those interventions, instead of picking up the pieces of the harm they cause, simple, cheap training of Cleft team professionals and midwives, neonatologists, scanners, ultrasound scanners, just on how to handle that first conversation will make a difference and stop harm. And I think we need to stop harm before we think of cure.
I can't agree more. I think what you're saying is incredibly important. We need to stop doing harm, right? And that comes with, I think that really comes with knowing how to act, right? Knowing what to say. And hence our recommendation for the training for the whole team, right? So that they can be aware. Julieta.
Bueno, yo también totalmente de acuerdo con que el abordaje psicológico, psicosocial, necesita traducción o...
No, you are having the translation, Julieta. If you go to translate...
Puedes hablar en español y la traducción se hace simultánea, Julieta.
Ok, entonces les decía que para nosotros como equipo de la Fundación Ainina Cuna es tremendamente importante incorporar a un profesional del área psicosocial, ¿no? Desde los primeros momentos, tal cual muchos lo han compartido, pero además como transversal en cada proceso de intervención, de todo este proceso de tratamiento. Y comparto con Jimena cuando nos decía de Fundación Gantz, es sumamente difícil poder conseguir un apoyo
Momento, por favor, momento. We're translators, we're hearing both equally. So for English people, it's really hard to follow. If you can just mute, I'm not sure there's a button you need to press to be able to hear. We're hearing both at the same time. Sorry, Julieta, disculpe. Continuar, por favor.
Yeah. Ok, entonces decía que esta parte del buscar financiamiento para esta área psicosocial y hacerlo sostenible es tremendamente difícil. En la Fundación Ainina Cuna nosotros hemos subvencionado este tratamiento porque entendemos que el rol del psicólogo y el trabajador social específicamente no puede ser sustituido por un otro profesional. Hay un rol específico, un entrenamiento en esta área. Y si queremos brindar información y abordaje de calidad a las familias, entonces necesitamos respetar los roles específicos de cada profesional, entendiendo esto como un proceso además largo, continuo, que inicia desde el nacimiento del bebé y que concluye hasta los 17 años en un tratamiento integral en el protocolo quirúrgico que manejamos, con el protocolo de atención integral. Entonces considero que deberíamos trabajar en instrumentos de repente objetivos, investigación sobre la importancia de poder enfocarnos en ese trabajo psicosocial de manera temprana para trabajar los resultados a largo plazo y poder hacer esta comparativa, ¿no? De un abordaje psicosocial temprano, poder mostrar la realidad en términos de resultados. Gracias.
Thank you, Nieta. Wow, this is a very fruitful discussion. How are we doing on time?
We're good on time. We have some time, and then there's also some questions in the chat as well. if we want to start addressing those.
Sure, that would be great. Taylor, are the questions that you're referring to the questions?
Yeah, I can start reading some of the questions out if that's helpful.
Amazing.
Yeah. So towards the beginning, and I'm just going to read all the questions. So if we've addressed them, just let me know. But Hugh had asked, where does an individual CCC team member start if the general understanding of the team is that psychosocial care is important, but is really someone else's responsibility?
I want to hear more about that question.
And then there were some follow-ups to that as well. So someone else kind of elaborated, can the team member not start providing that care themselves while waiting for the right person to be identified and brought in? And gave an example that they give their phone number to the primary care provider and invite them to call or message at any time if they need support. Several have taken them up on that offer, especially those with little support from their families. Often it's for reassurance, sometimes for the other healthcare advice, like whether to go to the clinic or see a doctor. And sometimes it's been in great times of distress. I know it's not ideal because I don't have formal training, but we do have a lack of resources. And then someone else kind of elaborated on that as well, that other Cleft professionals can be trained to provide psychosocial support as a question they wanted to know. And then they commented that it would be helpful if other professionals could do this, since these professionals are sparse in LMIC contexts.
This is exactly, I think, like, these are incredibly important questions, and this is exactly what I'm talking about when I say we need advocacy and funding. And even if we, like, in order to bring at least some kind of awareness to the whole team around how to speak to the patient. But when the resources are scarce, I think it's so important to have one contact person that they can go back to, so that having someone is better than having no one. But I think, you know, what we're getting to is that there needs to be more funding to have that awareness in each and every team member, so that there wouldn't be any harm done to the patients, in my opinion. But let me hear from Mariana.
Buenos días, muchas gracias. Estoy muy contenta de estar aquí porque pocas veces estamos en cursos donde se le dé tanto interés al tema psicosocial. Y yo estoy en México y uno de los problemas a los que me he enfrentado es convencer al personal médico, cirujano, anestesiólogo, de la importancia de este tema. Ya decían, aquí en México es tan larga la distancia que las personas no pueden venir recurrentemente y tenemos que aprovechar el día que vienen para ver todas las especialidades juntas. Y pues le damos más peso a otras y pues poco a poquito estamos logrando, y yo me he encontrado con la dificultad de encontrar estudios que demuestren a nivel médico también los beneficios de la parte psicosocial, como el sistema inmune se defiende mejor, cómo el estrés puede favorecer en la recuperación postquirúrgica, bueno, el no tener estrés, cómo hasta en la parte dental, que ahora nos enfrentamos a las caries, el estrés, la depresión, la tristeza, la angustia, pues favorecen a procesos médicos importantes. Y pues pregunto si por aquí alguien tiene, a veces hacemos investigación en nuestros propios centros y es difícil que los demás la encontremos. Entonces, ver si alguien aquí tiene esta información, algún estudio que podamos compartirnos, en donde también la parte médica se vea impactada con una atención psicosocial que nos ayude, o al menos me ayude, a poder dialogar más con el personal médico de las organizaciones y nos den más entrada a la parte psicosocial. Gracias.
Thank you. And what you said, Mariana, made me think of another point. And this is shout out to Hugh and Transforming Faces. maybe we can just host something around like what worked so far in other contexts, so people can share their experiences. Like even if they were, because we only know what's published, right? So what hasn't been published and what people are doing are so valuable for us to learn from each other. So that's what I was thinking when Mariana was talking about that. But if anyone has any tools to get buy-in from the medical professionals, please do share it with all of us. Diana.
I believe that my experiences, I believe that that the team, the Cleft team, the teams that we work with, they all want to do well. And echoing Dr. Felicity's previous words, I believe that it's also important to do this psychosocial training to the rest of the team, in the same way that we, other professionals, we need to understand part of the treatment, although we're not the speech therapists, we're not the surgeons, but we need to, the whole team needs to be informed of the processes, the time. So I think it's that's why it's interdisciplinary, but also the importance of having people that are trained psychologist or social worker, because sometimes we're going to find children that may have some suicidal ideation. And that requires someone that knows how to handle this. So sometimes it's easy to say, no, we can train a nurse, we can train a speech pathologist. There's many activities that we can do in those professions, in those capacities that will, of course, bring a benefit to the patient, but we're not like invading someone else's professional field, because what if we have a child like that and we don't read the cues? So that's why it's important as a psychologist, the social worker, the team do train the rest of the team in being able to read those cues, because if with only one child, it's enough that we found that we are not aware, we don't know how to handle, and then something happens. So that's why it's important to deal with trained people in each capacity,
Thank you. Felicity.
Beautifully put, Diane. My head was falling off my neck. I was nodding so hard. I just loved the point that Mariana raised. How do we prove that this psychosocial input makes a difference? And I would go so far as to say psychosocial input could maybe stop surgeons doing unnecessary operations, which is good for the patient. But if we're trying to talk to policymakers, it saves money. And it potentially saves complications and harm. The answer to bullying in school isn't always surgery. And I think I'd love to chat about this further, because it's I'm going to shut up there, but I think, Mariana, what a beautiful question. What a powerful way we could demonstrate this. And I think we need to pool resources to do that. And I say this as a surgeon, by the way.
Thank you, Felicity.
So Sanam, we have about 3 minutes left, just as a reminder, and then we'll be in approximately 7 minutes, we'll be going to the plenary, just as a last reminder.
Okay, so we have actually 2 minutes left, right? It's 11:33. So any last comments, or shall we go into closing? Oh, yes, Michael. Yes, Michael, I think you were raising your hand, right?
Sure. Just briefly, I wanted to respond to what Felicity just said. I ran into a young man on the coast of Oaxaca several years ago who had had a suboptimal surgical care of his cleft lip and cleft palate. However, his mother had done a remarkable job in helping this young man come to terms with what his face looked like. And our focus with this patient, this is Mateo, Diana, is now working on his speech, which is the most important aspect of rehabilitating him to recovery. We've talked to him about having a lip revision, and to date he has declined because his mother has done such a remarkable job in helping him to be comfortable with who he is and what he looks like. And this has become a part of his personality. It's not a bad surgery. It's not the very best. But what's important is how he feels about himself. And that was imbued by his mother and reinforced by our surgeons and our people on the ground in Oaxaca. So thank you, Felicity, for bringing up this most important point.
Thank you so much, Michael. And I think we need to close now. I can have these conversations all day. It was so valuable for me. So, and I hope that it was valuable for everybody. And what you're saying, I think, Michael, reminds me of like the importance of also, you know, what everyone was saying about like starting this process of support from the time of the diagnosis or from the time of the pregnancy, so that the mothers can be there for their children. Thank you so much, and we are gonna see you, I think, in the plenary.